Hello, everyone, and welcome to my practical ventilation talk. I want to give you a couple of words of wisdom about this lecture. This lecture is not intended for critical care folks. This is intended for emergency medicine. And in general, trying to explain to you a whole lot of information all at once, I had to really oversimplify everything. So I want this lecture to be a whole lot more about what you need to know when standing in front of that patient who's just been intubated. That said, let's go ahead and get started. The first and hardest question to try to figure out is, why is ventilator management so hard? The only answer I could come up with is four. And that is, it requires a lot of understanding about things that we haven't had to use in a lot of other fields of medicine, like a complicated understanding of things like physics and the inner workings of a computer. It also scares us off with things like new vocab, graphs, acid base, even. So I'm going to touch on a few of these things, but I don't think you have to know all of them to be able to manage your ventilator. I also think it's worthwhile mentioning that these are technology, and so they're always in flux, which means that a lot of the brands change. There's always new things being added. And even though the machines themselves look the same, there's a lot of differences in the newer brands versus the older brands, and vice versa. There's also a pretty heavy reliance on respiratory therapists. And I don't necessarily think that this is a bad thing for providers, but I do think that we need a little bit of practice in managing vents. Nothing has become more obvious, especially during the COVID-19 pandemic, that providers need to be able to have a basic working knowledge of ventilators. And we really just depend so much on respiratory therapists. The last and maybe the most important reason why mechanical ventilation is so hard to understand is that it's the exact opposite of normal breathing. When we breathe in, our diaphragm contracts and that sucks air into the lungs. This happens because of how strong that diaphragm is and how elastic those lungs are. It sucks the air in, and then when we expire, we just release the diaphragm, which, because of the elasticity of those lungs and the relaxation of the muscle, the air just kind of flows out very passively. When we're intubating somebody or letting the ventilator use and work this air, we are actually forcefully shoving that air into those lungs. Again, exact opposite of how we're actually breathing. And then the machine kind of sucks the air back out with a bunch of negative pressure. So we're forcefully pushing the air in and sucking it back out with every breath, which does lead to lung damage and tissue damage. So just being on the ventilator in and of itself leads to lots of problems. Now, why do we do it this way? And why can't we have a more physiologic way to do it? The answer is we used to. We used to use iron lungs back in the decades of polio. This created that negative and positive pressure in the same way that we breathe. But we switched. Why? The sad answer is it's less convenient. It's less convenient for the doctors because we can't complete an exam. It's less convenient for the nurses because they can't put in a Foley. It's less convenient for patients because they can't move around very well or feed themselves or whatever else we want them to do. So we've changed over to the ventilator machines that we have now. Knowing this, let's talk about what you actually need to know when you stand in front of a patient. This is my overview slide of all of the things that we're going to cover in this lecture. Start with things like when to intubate, ventilator inputs, modes of ventilation, troubleshooting, and some special cases. I think that's all you really need to understand for a basic rudimentary understanding. So we're going to go over these four ventilator inputs: respiratory rate, FiO2, PEEP, and tidal volume. There are more, but these are the most important. Then we're going to talk about ventilator modes. Now, these are just a few that we're going to talk about, but there are so many, and there are more and more and more ventilator modes that are being introduced even as we speak. There's one that I read about that's probably a little bit older now that has an esophageal probe placed into the esophagus. Obviously, that's why it's an esophageal probe. And it senses when the body's muscles contract, and that's how it determines how to deliver breaths. Very cool, very cutting edge. I don't think that most hospitals are going to have that. So, we're going to talk about the ventilator modes that are the most common and the ones that are the most basic to understand. Then we're going to cover all of the problems that are associated with mechanical ventilation. We're not talking about the nitty-gritty specifics. We're talking about big stuff that applies to almost all patients with mechanical ventilation. But first, we have to talk about the most important question, or questions, if you will. And I know this isn't an airway talk, but we have to talk about it. When should you intubate and when should you not intubate? That question pretty much implies, should this patient be on the ventilator or should this patient not be on the ventilator? Okay. There's a lot of answers to these questions and a lot of debate in the medical world about what should and shouldn't be considered on this list. But I would say that overall, other than what I've included here, the differences are when you intubate is usually a failure of the airway. That's the tube system that actually gets air into your lungs. Whereas typically, we don't immediately jump to ventilators if the failure is the oxygenation of the blood. So it's not the tubes and it's usually not the lungs, it's the oxygenation in and of itself. We're going to talk a little bit more about that shortly. But I also have a lot of students out there who tell me they know the immediate answer and the easy answer to these questions. The answer is respiratory distress. And in that vein, my answer to them is, what is respiratory distress? This may seem like an obvious question, maybe even too basic, but it's important that you're able to describe what respiratory distress is and looks like, not just for me and not just for your future, but also for your documentation. Remember that in Epic or any other EMR, you can't just click the respiratory distress button and use that as enough rationale to intubate your patient or to manage your ventilator. You need to know and have the description that's mentioned up here on the slide. For example, you'll notice this gentleman is in tripod position. You notice that he has flared nostrils and pursed lips. You notice that he's using his accessory muscles, specifically those little tiny muscles in between each rib, the intercostals. Notice that he's already on oxygen, and he could have things like altered mental status or blue discoloration. These are all very key findings in what we want to describe in our documentation for our respiratory distress patients. So be sure that you can describe this beyond just a simple, yes, the patient's in respiratory distress. I would also add on here how many words that a person speaks. So if they're able to describe to you in detail how they are short of breath and that they're not able to articulate and they go on and on and on for 5 to 10 sentences, they're probably not in that much respiratory distress. Whereas somebody who can only answer you in 2 words at a time before taking a deep breath, that person is more so in respiratory distress. So I do like to divvy up respiratory distress into the 2 categories that we kind of went over earlier, and that is a failure of oxygenation and a failure of ventilation. Now, obviously here, ventilators go with a failure of ventilation, right? That's the ability to get air into the lungs. If it's a failure of oxygenation, ventilators can't often fix an oxygenation problem. That's why we need the airway spectrum. I know it's kind of janky. I made it myself, but what you understand here is that there is definitely a stepwise progression. You don't have to jump immediately to walking in the front door or nasal cannula immediately to intubate or ventilate. There are multiple other modalities that is worthwhile to try. And I would encourage you, if the patient isn't about to code, don't skip all of the steps. Try at least one other step before you jump to that intubation and ventilation. And hopefully, you never make it past that step into criking somebody. That being said, there are reasons to skip steps. And I'm going to leave that up to a little bit later when we talk about respiratory distress in our cardiopulm section. But please know that there are lots of other steps, and I would prefer that you try at least one other step if you have time. Now, the way to know whether or not we have time to do other steps or not is to let our ABG be our guide. But it's not just the ABG. Remember that we're not tied to numbers. We also want to look at the patient. And that's why I've included a respiratory distress patient on the slide. You want to match your ABG to your patient. Now, that said, when you look at an ABG, I know that so many people panic. But we're talking about a functional ABG and how it's guiding you into whether or not you need to intubate this patient and whether or not this patient would benefit from a ventilator. So you can ask yourself very simple, easy questions. Nothing like, is this compensated or is this not? Ask questions like, is the CO2 high or low? Does that make sense with the respiratory rate? Is it affecting the pH? What about your oxygen? If your oxygen is low, ask yourself, is this a venous sample or is it arterial? Remember that respiratory therapists, nurses, and even doctors and other practitioners don't always get an arterial sample. Maybe it was accidentally venous. Now, which one of these is more commonly the problem, the CO2 or the oxygen? The answer is the CO2. Now, we kind of already got into this a little bit, but when you choose a VBG versus when you choose an ABG, and we're already talking about respiratory distress here. So the answer to this question is when you can't get an ABG. Remember that a lot of these patients are already really sick. Maybe they have low blood pressure on top of having a respiratory distress issue. So typically, if you're talking about respiratory distress, you need an ABG. But if you can't get one, a VBG, knowing it's a VBG, is okay to give you general guidance. Notice that your pH isn't that different from ABG to VBG. You should also notice that your PCO2 is only a couple of points different. So you can get some general guidelines if your patient is too sick and you can't get an ABG line. Just go ahead and send off the blood and get a general idea of the pH, knowing it's not 100% accurate. All right. So it is important that you know that complicatedly, your body is more sensitive to CO2 changes than oxygen changes. Typically, even your venous blood has at least 70% oxygen attached. That said, your body does really well with that. Remember that we've evolved for a 21% oxygen. So, in our atmosphere, that is, of course. So, if you think about high or low CO2, you always think about CNS symptoms, which is why we have to pay very close attention to the carbon dioxide here. And that's why the goal of intubation is really twofold. It's just to decrease the work of breathing and it's to maintain your minute ventilation, which is a fancy way of saying that we need to maintain your metabolic need to get rid of your CO2. So, really, the goal of intubation, we need to pay very close attention to this CO2. Now, that said, I want to get this out of the way. Let's talk about some of the things that we learned from COVID about ventilators. Some of the most obvious and easy things are you need to match the ABG with the patient's exam. Just because the ABG looks bad or looks good doesn't necessarily mean that that's telling you what to do. You need to match that ABG with what the patient looks like. Do they look like they're going to tire out soon? If their ABG looks awful, but they're sitting up and texting you, maybe intubating and ventilating this patient is not needed. The other question is the extra oxygen actually helping the patient? This seems like an obvious, stupid question, but if we take it one step further and ask, how do we know? This is something that is really important that we think through. This is also something that would have really improved our care for the COVID-19 patients in the very beginning of the pandemic. I'm going to give you an example of an experience I had. I was called upstairs to the ICU in the early days of the pandemic because one of the nurses let the doctor know that this patient was continuing to require higher and higher levels of oxygen until he was finally on the 15-liter non-rebreather that we had at the time. And she wanted the patient intubated because he still wasn't doing very well. So, when I went into the room and I assessed the patient, I determined that this patient did not need to be intubated. And even though his SATs were 76, she was furious at me. And one of the questions I asked her is the extra oxygen actually helping? And she says, of course, his SATs are 76. I keep having to turn the oxygen up and up and up and up. And so what I had to do was say, well, I'm going to prove to you that the extra oxygen is not actually helping this particular patient, because the only reason to intubate is that he needs even more oxygen requirement, even more ventilation. So what I did is I turned off the oxygen completely. And you know what the SATs were? They were still 76. And when we turned the oxygen on, they were still 76. And when we looked in his chart to see what his oxygen sat was from yesterday, it was still 76. So if the oxygen is turned completely off and it's making no difference, it's not desatting in any way, then adding more oxygen isn't making a difference. And ventilating that patient is probably not the best step forward. And we finally learned that from the COVID-19 pandemic. Now, this doesn't mean we give up on these patients, of course, but it doesn't mean that we need to intubate everyone either. So I would encourage you that if you have a patient in respiratory distress that's arriving into your emergency department or even into your clinic or urgent care, and they're already on nasal cannula, as they so often are, because the paramedics say that their SATs were low, when I'm doing my assessment, part of my assessment is to turn the oxygen completely off. See how low they go. Do they only go to 91? Or do they go down into the 70s or 80s? This is an important part of the physical exam, and it's something that you need to be sure that you answer. Another big thing that we learned from the COVID-19 and the ARDS is prone positioning. Now, I want to make sure that everyone knows that we did not invent this because of COVID-19. It just became very popular. We've known about it for a long time due to ARDS. And it does apply to almost all long-term ventilated patients. And it can apply to almost all patients who have respiratory issues. That said, this diagram kind of explains it in really intense detail, and that is twofold. Notice that in the supine position, we're using gravity here, and whether this patient's lungs are full of fluid, most of the fluid goes down to the bottom part of the lung. Not only does that crush the lung, but that's also where the majority of the blood flow is, because the blood is liquid, right? And it goes down to where gravity is. So that means all the air is in the top lung, but almost no blood exchange is happening because all the blood is in the bottom due to gravity. So when we flip the patient over, this moves this on the head, which means that almost all of the fluid that's in the lung tissue is going down towards gravity, turning down by the chest or the sternum. And yet the blood flow is still in the posterior lung because of vasodilation and vasoconstriction. This means that we actually get increased oxygenation. Now, this isn't magic, right? It's not that the prone position is so much better for breathing. It's moving of the positions. So it's important that you understand that the power of the proning position is that we move people from just off their back to on their chest and back and forth every 8 to 12 hours. We don't know exactly how long is best, but the importance of this is that we're moving and changing position, not necessarily that prone position is that much better. We're also trying to use gravity to our benefit. All right, now let's actually get talking about these ventilators. So I realized that all ventilator screens look a little different, but I had to choose one to start with. And I also told you guys I wouldn't be using a whole lot of graphs, but you should know in general what the screen is showing you. So you can see up here that the yellow graph on the very top of the screen is showing our pressure charts. The middle graph, or the green one, is showing our airflow in and out. And then the bottom one is showing our volumes. You should know that every single ventilator, regardless of the brand, is going to show you all three of those. We can also see here at the very bottom in green that there are 4 different inputs, usually associated with some knobs to be changing. So those inputs we're going to be talking about here shortly. You can review these graphs if you want to, but I don't think that's the most important part in managing a ventilator, shockingly. For those of you who want to know a little bit more or who have already done studying on ventilators, there are 2 definitions I want you to see, and those are both covered on the bottom. That is peak pressure and plateau pressure. You're going to hear a lot about those if you start studying vents because they throw those terms around like it ain't no thing. But peak pressure is essentially just the highest pressure experienced by the lungs, aka it's the maximum pressure that the ventilator is giving to the lungs or that the lungs have to withstand. And instead of necessarily looking at all the graphs for that, most ventilators will come and just read off to you the peak pressure. So if they're talking about the peak pressure being too high, it means you're blowing the lungs out with the pressure, turn it down. The plateau pressure is the pressure that's required to open the alveoli. And this is something that we want to make sure of because remember that we're sucking the air out of people's lungs. And we want to make sure that there's pressure left inside your alveoli so that way it can stay inflated rather than completely deflated. All right, let's actually get to talking about these ventilator inputs. I'm talking about ventilator inputs first because regardless of what mode you choose, all of the ventilator inputs are going to remain relatively the same. So this Envy is a different kind of or brand of ventilator than the previous screen, but you can see that all the screens are going to be different. These ventilator inputs that we're talking about is respiratory rate, or just the number of rates, or the number of breaths per minute. FiO2, which stands for fraction of inspired oxygen, aka it's the percentage of oxygen that the machine is giving to the patient. PEEP is positive end expiratory pressure. So it's the pressure at the end of expiration, aka the pressure that it takes to keep that alveoli open so we don't suck them all the way closed. And then tidal volume, or the volume of air that we get per breath. Now there is one more input called the IE ratio. The IE ratio can only be changed on some modes, but it's essentially the amount of time that you have for inspiration versus expiration. This timing is specific to COPD patients, most importantly. We're going to talk about it a little bit at the end, but it's most closely related with your respiratory rate. I'm not going to go into this. Talk to your respiratory therapist if you have a bunch of questions about it. So let's talk about these inputs in general. First is the PEEP. So PEEP shouldn't be going to super low ranges, right? You want probably a minimum of 5 for any adult patient because we don't want that balloon to close all the way. You can see from this picture that this deflated balloon closes the balloon. And remember that without that surfactant, it's really impossible to open those up. That leads to atelectasis, that leads to less gas exchange, and that leads to lower oxygen sats. We don't want that in a sick patient who's ventilated. You can also see the effects of PEEP here in this picture. You can see this CT scan where somebody has a PEEP of 0. And then when they change it to a PEEP of 19, you can see how the fluid has changed in the lungs and how they're getting more oxygen now with a higher range of PEEP. This is why that if your lungs are full of fluid, your PEEP needs to be higher. Also, if you're requiring higher amount of oxygen, FiO2, right? It should probably be higher than 5 if your FiO2 is over 60. Now let's talk about that FiO2. It typically ranges from 20 to 100%. Most ventilators do not go down below 20, which is good because that's what the atmosphere is. So your goal is to get your FiO2 the lowest you can get it to, or so you have a PO2 sat of 60 and above, right? You don't have to go to 100%. That's important that you know, because we want to be aware of oxygen toxicity. Now, in case you don't know, oxygen toxicity is a really big deal, and we're talking about it a lot more and more. Too much of anything is bad, right? Now, when you're learning about food in school, probably as a kid or from your mom, you might learn that blueberries are good for you because they're antioxidants. Well, maybe what you didn't realize is that antioxidants being good and oxidants being bad, oxidants come from oxygen. Oxygen causes free radicals that damage your DNA. I know that's a gross oversimplification, but it is the truth. So, oxygen can damage our DNA and cause cell death. There's a lot of studies that have been done about this for divers, NASA space astronauts, and even in hyperbaric chambers. We know that 100% oxygen is more sensitive to your brain, your lung, and your eye. This means that you can have things like seizures and you can even have brain death. So please know that too much oxygen is a problem. And especially if you have a sick patient with sick lungs, you don't need to go and have 100 FiO2. And you also don't need to have 100% SATs. Several studies have often showed very recently that if you keep a critically ill patient at 96, I'm sorry, you want to keep them between 94 and 96 for peak mortality rates. You don't want them at 100%. This is especially true for folks who are COPDers who probably live in the low 90s. They do not need oxygen sats of 100%. This can also be true of our babies. So remember that oxygen is not always a good thing. So other ventilator inputs are our tidal volume and our respiratory rate. So our tidal volume can be calculated. And if you're interested, go ahead and feel free to look that up. But in general, it ranges between 6 and 8 ml per kg. And we all know, because we work in the emergency department, that a lot of our patients tend to be a little bigger than they should be. So we like to use ideal body weight, which essentially means we're using height. Because remember that our lungs don't get bigger or smaller if we gain or lose about 5 to 10 to 20 pounds, right? So as long as you understand that lung size changes by sex, it's actually one of the few things that does not change by race. These are very easy to look up charts by height, and you can see one on the side here of this slide. Notice that it's the male one though, not the female one. Remember that too much tidal volume can cause those plateau pressures to be really high, which can cause a pneumothorax. So we really don't want to do that. Respiratory rate usually starts at around 12 and you can go up to about 35. Some machines now are starting to go over 35, but a lot of them intentionally don't. Not because we can't, but because we want to allow enough time for the machine to refill air in and out of the lungs. Now, there are times when you don't want to start a patient at 12 or 14, which is the typical. It is important to know that the respiratory rate can be increased to hyperventilate the patient on purpose to help blow off CO2 if there's a whole lot. This is also important for patients who need to change the IE ratio, because remember that the faster you breathe, the shorter the amount of time you have to breathe in and out between each breath. So now we got to talk about how we optimize the vent. And I realize we haven't talked about the modes, but just assuming this patient's already been intubated, Once you get your patient on the ventilator, leave them on it for about 10 to 15 minutes and then get an ABG. If you want to improve the oxygen because it's too low, the two dials or inputs that you mess with are the FiO2 and the PEEP. And if you need to improve or decrease the CO2, the two dials that you need to mess with are the respiratory rate and the tidal volume. This can just be straight up memorized if you want to. But the more that you see it and the more that you get used to it in practice, the easier it is to remember. I also want to note that I've listed these in specific order. That means that if you want to improve oxygen, you don't just randomly pick FiO2 or PEEP. Really, you should be starting with FiO2. And only if you max out FiO2 do you need to go to PEEP. The same is true about CO2. We want to use respiratory rate first before we start adding a whole lot of extra volume. This is all true because PEEP and tidal volume are more invasive and have more side effects at higher numbers than does FiO2 and respiratory rate. So these are the normals for typical ABGs. Let's go through a couple practices. Remember, don't panic. I'm not asking you like a test is about compensation or really what's happening. What I'm asking you is what's wrong with this patient's ventilator and do we need to make any changes? Let's start with ABG number 1. Notice that all these values are off, probably because this patient was sick and had to be ventilated. The biggest one to note here is that the oxygen is way too high. So we could either turn down the FiO2 or we could decrease the respiratory rate. In this particular case, we want to do both because we also see that the CO2 is a little bit low. This patient could be hyperventilating, so we need to just decrease that respiratory rate, calm them down, and see if that ABG improves. Remember that each one of these vent optimizations are going to be your best guess based on that ABG. You give it another 20 to 30 minutes, and then you can order another ABG to see if your guesses were correct. Let's go on to ABG number 2. What you can notice here is that the O2 is in the normal range. So we see that the CO2, however, is not. It's 78, which is way higher than 45. So this person needs to increase the respiratory rate because we need to decrease the CO2. They're probably having a retaining issue. Now, what about the ABG number 3? What you're going to notice here is that this person is not acidotic. As a matter of fact, their CO2 number is very, very low. This person needs a decrease in the respiratory rate because their CO2 is too low. Now, what about this ABG that's in the picture here? Notice that that CO2 is 102. That's pretty high. Now, their O2 is slightly low, but what we can do for this is we can increase their respiratory rate, and hopefully that will fix both the CO2 and the oxygen. Now, before you ask, I know a lot of you are worried because you're saying, well, how much do I change it? The answer to that question is how much is it off the baseline of the normals? And how sick is this patient? Maybe this patient, the last one that we did with the CO2 of 102, maybe that patient is a known COPDer and they have a previous ABG showing that they were 78 like this before. So maybe that means that we only need to change the rate by 4 or 5 points. Remember that we're making a guess based off of how much we want the patient to change. We also know that just like anything else in medicine, we probably need to taper the change rather than have sudden complete normalization of all of the lab values. So I would probably recommend changing anywhere between 2 to 6 numbers for respiratory rate at a time. For FiO2, we usually go by 10s or 20s. PEEPs, we go by single digits. And tidal volumes, we typically go by hundreds. So if they were at a tidal volume of, I don't know, say 550, I might go down to 450, depending on what the CO2 looks like, right? So always let your ABG and your knowledge of the patient be your guide. Now, finally, let's get on to ventilator modes. Ventilator modes are essentially just how breaths are delivered. Notice that there are so many different kinds of ventilator modes. And like I said at the beginning, I haven't listed them all. This is also where a lot of people tend to get very confused. Part of the reason why they get very confused is because the definitions across brands and across journal articles or even textbooks are not consistent. Frustrating? Absolutely. Is this improving? Yes. It's also something that you should know that each brand adds extra features. So one brand's assist control could also have pressure support and CMV like effects, whereas another brand doesn't have any of those things at all. Rather, I think it's a lot easier to start thinking about ventilator modes like you think about a search engine. You could have your favorite. Most people use Google, but maybe you love Bing or you're still stuck on Yahoo. Because you're more familiar with it and you're more used to how it works, you're better at using it. And if I gave you a topic of information, I could probably have somebody who uses Yahoo and somebody uses Google get to the same information or the same destination, regardless of which search engine they're using. The same can be said about ventilator modes. While there is a more efficient search engine or ventilator mode to use, everybody can get to close to the same answers with or outputs with ventilator modes. It's just what you're more used to and what you're better trained with. It's also what your hospital has available. So there are two different ways to organize these ventilator modes. And I know I promised you no physics, but this is basic, I promise. So one way to organize ventilator modes is whether it's a pressure mode or a volume mode. What you need to know about volume and pressure, especially where ventilators are concerned, is that these are an inverse relationship. So you can see by the jars at the bottom of the screen that if volume is up, pressure is down. And if volume is down, pressure is up. Think about the seesaw situation. Okay. I don't think that's too hard to understand. The other way to organize ventilators is types of breaths. Now, there are three different types of breaths: mandatory, assisted, and spontaneous. And the best way that this was ever explained to me, and the way that I understand this the best, is with a pull up. Now, what you need to know is breathing is the pull up. So if you look down at the spontaneous type of breath, that is a real awesome, super in shape dude who can jump on that pole and use his own muscles at his own time, at his own pace, and he can pop his chin above that bar and go back down and do it over and over and over again. This is what you do when you're breathing right now. You are using your own muscles and your own timing, and you are going and putting your chin above that bar and you're filling those lungs. Now, contrary to that is mandatory. And I know you've all seen that one girl at the gym or that one dude at the gym who's like not using the machine right. And they get on this pull-up machine and they could basically take their hands off the bars because the machine is doing all of the work, right? They don't really need anything other than to kneel on the little piece, and the machine is going to take them up and down. That's what a mandatory breath is. It's the machine doing almost all of the work. Finally, we get to the middle ground, or the assisted. This is like a banded pull-up. Notice that this girl who's doing this banded pull-up has to initiate the movement. She has to use her own biceps and her own back to start the movement, and she does get to control the timing of the movement, but the band takes off a lot of the work. It completes the move for her. So if she couldn't do it spontaneously, she can start to earn up to it with an assisted breath. Okay. Notice that vents are going to be this way. A mandatory breath has its place. It's best in sedated or paralyzed or incapacitated patients, whereas assisted type of ventilators are going to be best in partially healthy or capable lungs. People who may not have all of the musculature to do the work, but are able to still have their brainstem initiate their response. Don't worry, I'm going to take all of these pictures and we're going to compare them all here shortly. So here is a bunch of the ventilator modes that we're going to talk about, and they're divvied up into volume and pressure. And you can see that some of these modes are more heavy on the volume, and some are more heavy on the pressure, and some are right smack dab in the middle. Here are those same ventilator modes reorganized into the types of breaths. Some are mandatory, some are assisted, and some are right smack dab in the middle. Again, the good news about this is if you're not a respiratory therapist, you don't have to memorize all of these things. This is how most of the ICU books and the ER books talk about all the different types. And if you're a chart person, that's great. But I don't like learning this way, so I'm just going to skip this. So the big question is, how do you know which to pick? The good news is I'm going to give you a cheater method at the very end. But what you really have to understand is all the intricacies of the differences between each ventilator mode. And a lot of that comes down to two things: the patient's lung health and the patient's condition. So when I'm talking about lung health, it's all about why this patient was intubated in the first place. Was it because they were a psych patient and they were kicking and punching all of the staff and their lungs are really not the issue? Or was it because this patient is sick and has asthma or COPD, or they have fluid filled lungs, or they're COVID? Those fluid filled COVID lungs probably can't handle the same kind of pressure or mandatory mode or assisted mode that somebody who doesn't actually have any lung problems, right? It's also dependent on the patient's condition. Did you just intubate them? Are they still paralyzed? If they're still paralyzed, you probably shouldn't put them on an assisted mode, right? So let's talk about two of the differences. You don't have to know the very specific modes, but I wanted to take the most extreme examples so you could understand the difference between a mandatory mode and an assisted mode. So CMV stands for continuous mechanical ventilation. This is a mode where the machine determines when and how the breath is delivered. The patient gets absolutely no say. They absolutely can take the hands off of those handlebars, right? And because the machine determines it, the patient can get damage in their lungs if they're holding their breath or fighting the vent. And they can also cause problems if the machine is trying to breathe and the patient is trying to breathe at different times. Now, remember that CMV is an extremist mode. And not all mandatory modes are this extreme. So notice that just like in the gym with this machine, you can turn and change this weight to be a different weight to where the patient has to do a little bit more work, or the gym goer has to do a little bit more work to get up to being able to do breathing on their own, even though the machine is still completing most of the work for them. So how much weight on the machine determines how much help they're getting. The same can be true about mandatory ventilators. Now let's go to the opposite side and talk about pressure support. Pressure support is the most extremist assisted mode out there. The patient determines when they get a breath and how much breath is delivered. That's tidal volume. But the machine sort of finishes the move. It assists the breath by providing a certain amount of tidal volume or FiO2. The problem with this mode is that if the patient is too tired or cannot initiate the breath, the patient doesn't get one at all. Or if they can initiate it, but they can't complete the complete pull up, they can't get that chin quite over the bar, and they can't take as big of a deep of a breath, they may not get all of the ventilation that they need. So, how thick the band is, or whether you have just one foot in it or both feet, determines how much help you're getting. So, just like with the mandatory, there is a spectrum in the assisted ventilator category that provides you more information. And there are plenty of different modes that provide some sort of middle ground between assisted and mandatory. Now, let's move on to pressure versus volume. So, both of these modes are mandatory. So, volume control means that you only set a tidal volume. This is something that we can calculate, like I talked about before with height. This allows for consistent and calculable minute ventilation, which is how we control that CO2 metabolism. However, when it's consistent and calculable, it may not necessarily always be what the patient needs. That means that we risk barotrauma or popping lungs or causing lung damage because we're only giving them the volume that we're calculating. That said, we're also ensuring proper ventilation. This is why most volume control settings are preferred by most providers, because that is, after all, why we put this patient on the ventilator to ensure that proper minute ventilation. Now, let's compare this to pressure control. That's where we set a specific pressure or PEEP. The good news about this is that there's a lot less of risk of barotrauma. We're not going to blow out the lungs. But the other problem is that we're guessing at a PEEP because we don't have a calculation for it. There's not a consistent way to deliver our minute ventilation because the patient is determining how much volume they're taking in. And so it could be different breath to breath. This is a good mode for those folks who are like neuromuscular diseases, or they were like psych people or trauma people with healthy lungs. And it's also preferred because patients like this because it's more comfortable. So you can see the differences between the volume control and the pressure control mode, but they both have their issues, which is why they invented pressure release volume control, or PRVC. This is a very popular mode right now, and it's a hybrid mode between both volume and pressure. You get to set the calculable tidal volumes for that consistency and proper ventilation, but the machine puts limits on how much pressure the patient can get. So you're having the best of both worlds: the comfort, the safety of not having as much barotrauma, but the consistency of the calculatable minute ventilation. PRVC is very popular right now. Now let's cover some of the most common modes. These are the two most common modes that exist right now in the medical world. The first is assist control. The cool thing about assist control is that, so both of these modes are assist modes, but assist control can either be pressure or volume set, and it allows the patient to initiate those extra breaths. So when the patient initiates the first breath and the second breath, but a patient actually wants a breath in the middle, the patient initiates it, but the machine actually does the full breath for them. So we know for sure how much volume or pressure that person is getting. And you can see in this little waveform down here that when they have this little Q wave, and I know it's not an EKG, but I'm going to call it Q wave anyway. When they have a little Q wave down here, that means that the patient is triggering the breath, but the machine actually delivers the full amount of breath. This is a good thing because if the patient was unable to take good breaths before, they're now able to do so, but they are allowed to hyperventilate, which is a big negative of the assist control. We're going to talk more about that here in just one more slide. But let's compare this now to the SIMV setting with pressure support. SIMV stands for spontaneous intermittent mechanical ventilation, quite a mouthful. And this is a volume control. This allows the patient to initiate extra breaths just like the assist control. But instead of delivering the extra breaths, SIMV lets the patient do all the work of their own extra breaths. So you can notice here that the machine delivered this breath and the machine delivered this breath, but the breath in the middle that the patient wanted, they had to do all the work for. And you can see that it wasn't that good. They weren't able to suck in a whole lot of pressure or a whole lot of volume into that breath. So the big negative of this is that their own extra breaths can be inadequate. But this one is really good for weaning because it allows the patient to start using those muscles again and build back up their strength, especially if they've been on a ventilator for a little while or if they've been really tired by having to breathe all the time, like in a COPD type case. Now, one of the most confusing parts about assist control and SIMV, because you can see the differences here, is that if you have a paralyzed patient, like somebody who's gotten rocuronium, and or a patient who's not making any or initiating any extra breaths, these two have absolutely no difference. So let me say that again. If the patient is not initiating a breath or they're paralyzed, these two modes look exactly the same because they're just delivering those breaths as they were set. So the only difference between these two modes is actually what happens when a patient initiates an extra breath. Now let's talk about auto cycling in the assist control mode. So we just talked about the assist control mode, and we also talked about the fact that the patient's allowed to hyperventilate. This is a problem with assist control mode, and I want you to know about it because it gives you a general understanding of some of the off-putting effects of ventilating. Auto cycling is called the vent version of the VFib, right? You can see that in the graph on the side. The vent is actually interpreting either tremors, seizures, or shivering as attempts to initiate breaths. And remember that the AC mode delivers those extra breaths every time the patient tries to initiate. So the patient is essentially getting something like 50 breaths a minute. Even though they're not trying to breathe that fast, they're just having seizures or shivering or tremoring. This can cause a lot of acidosis. It can cause a lot of metabolic issues. It can cause breath stacking. And really, this has to be addressed pretty rapidly. So the first thing that we're going to do is we're going to disconnect the patient from the vent. And then you only have two choices. You either paralyze the patient and put them back on the vent so they don't have tremors, seizures, or shivering, or you put them on a new mode where maybe like SIMV, where maybe they're not going to have this auto cycling issue. Now, this wouldn't be a very good vent lecture if we didn't talk about the superiority of the BiPAP. BiPAP is superior, in case you didn't know, to all ventilation modes. So let's talk about this. It's machine assisted breaths. So it allows you to set the PEEP and the FiO2, but the patient is responsible for initiating the breath and they're responsible for the respiratory rate. The machine and the patient both share the tidal volume. The main difference that we have in a BiPAP machine and a ventilated machine is how invasive it is. Notice that this person is connected to the ventilator with a mask rather than with a tube in their trachea. This means that the patient doesn't have to overcome the resistance of the ET tube and they don't require sedation. Those can both be really positive things, especially when we talk about the side effects of those later. And because it's not as invasive, there's less complications. We can also technically use BiPAP on do not intubate or do not resuscitate patients. So those are all lots of big pros. Now let's talk about the cons. The cons are that if the patient doesn't initiate a breath, just like with all other assisted modes, there is no backup in place, so they won't breathe. Also, having this mask over your nose and mouth, shoving air into your lungs and sucking it out, isn't exactly super comfortable or fun. And this is very anxiety inducing for most patients. Some may even require a small amount of Ativan to calm down and combat a little bit of claustrophobia or discomfort. The important part is to not over sedate and just make them a little comfortable. I also want to talk about the settings of a BiPAP because the settings of a BiPAP are listed up here for you. The usual setting is like 10 over 5. And the top number is the inspiratory pressure or the IPAP, and the bottom one is the EPAP or the expiratory. Think of this as the top number being the tidal volume and the bottom number being the PEEP or the pressure that we're using to hold open those alveoli. So if you think about it like that, you're able to easily make some changes to the BiPAP if you need to. I also want to bring your attention to this green box up here of reasons not to use a BiPAP. These are really important to know. And of all of them, the one that is probably the most confusing is all about altered mental status. So if you technically have altered mental status, you're not supposed to be using the BiPAP because we want the patient to be reliable enough to initiate their own breaths. We just talked about that. However, if a patient is technically altered but can still initiate their own breaths, can they use the BiPAP? So, case in point would be a demented patient who's had Alzheimer's for the last 10 years and is hugging a teddy bear. Can they really not be trusted to take their own breaths? Or do they just not know what year it is and it's okay to use the BiPAP machine? I'm going to leave that up to you. But I would say that I would give that patient the BiPAP, especially knowing that I don't have to give them all the risks of intubation, because I don't really think they need to know what year it is to breathe. The other reasons not to use a BiPAP on a patient would be somebody who's got intractable constant vomiting or got GI bleeding, especially because all that stuff is going to be then aspirated. Same goes with the respiratory secretions. If they're drooling a lot, maybe because of cerebral palsy or some other MR issue, those patients we don't want aspirating, so we can't use BiPAP. And the last reasons all have to do with mask issues. If the patient has really abnormal facial hair, if they keep ripping the mask off, or if they got some kind of trauma, fracture, or facial burn, or that kind of thing that would impede the ability of the mask to seal, we can't use the BiPAP. All right, I think that covers BiPAP. Don't forget that you need to optimize all of your vent settings, which means that you need to make sure that we have adequate sedation, plus or minus a paralytic. And we also need to repeat that ABG in about 30 minutes to make sure that all of our changes were as good as we thought they were. All right, let's go with just a few cheats. Consider using BiPAP first. That's always the biggest cheat. The next one is if you don't know what else to use and you kind of have to throw a dart at it, always start with assist control on these settings. These settings work for most adult patients, at least initially, and we can work our way to figure out where they're more comfortable from there. If you have a patient that you're wanting to wean, even if all of the nurses or the medical students are telling you that the patient is responding to commands, never extubate a patient unless you know their muscles can handle the work of breathing. And the only way to do that is to either pause the ventilator or to switch them over to SIMV. There's a couple other modes, but I'm not going to get into that now. Now let's get into some of these problems that I keep talking about with mechanical ventilation. These are all listed. Notice that this is a great wide spectrum from things related to intubation all the way to things related to the mechanical ventilator itself, complications with oxygen, et cetera, et cetera, et cetera. The four big ones that I want y'all to know is these. The first one is if you have a high PEEP, that's high pressure, that increases your intrathoracic pressure, which pushes on all of the areas or all of the organs inside your chest. So that hyperinflates the lungs and it pushes on the heart. Pushing on the heart, especially squeezing it, can cause a decrease in blood return, especially if the heart is weak or if the PEEP is high. And that can cause hypotension. So you can fix the oxygenation problem, but you drop the blood pressure, that's not working out well for you. So be careful because we often have to balance blood pressure with the PEEP. Another big one to know is that we can get alveoli overdistension. That can cause a pneumothorax or it can cause villi, which is ventilator induced lung injury, which we'll talk about shortly. The third one is if you've been on the vent for a very long time, that will eventually cause your muscles to atrophy in the same way that sitting in a chair for a long time will cause your muscles to atrophy. This can make it to where you are awake and conscious, but unable to come off of the ventilator. Be aware of that, especially in our patients with muscle weakness or muscle diseases, and in our patients where they have to overcome very large amounts of pressure or volume to breathe. And last but not least is our natural response to fight the vent. Remember that the patients aren't being jerks because they're fighting the vent. They really don't like having that tube in their throat, and you wouldn't either. This could mean that they need prolonged sedation or paralysis, and those all have long term health repercussions. This picture here is showing you what an ET cuff tube can do over a long period of time. Eventually, that pressure can cause necrosis of the trachea. That never turns out well. You can also get patients with bed sores because they're not moving, muscle atrophy, and more than just the breathing muscles. You can get aspiration pneumonias or regular pneumonias. You can also have poor nutrition because it's awful hard to feed a patient on the vent. There's a lot more, but you get what I'm saying. So let's talk about ventilator induced lung injury or VLI, right? It looks like ARDS, but the cause is unknown. The importance to understand is this: ventilating a patient, because we're having to guess their biologic functions, is never exact. And that causes damage to the tissue. Forcing air in and sucking air out is never fun for the lungs. And while it may be required to save a patient's life, it is something that you need to think twice about. You can see up here that these are mice lungs. And you can see what normal mice lungs look like and what lungs look like after 5 and just 20 minutes of ventilation. You can see how much swelling and damage is caused by ventilation. Please note this. Know that ventilating is not free and clear. Patients who ask to be knocked out for a procedure, they don't really know what they're asking for. Villi looks almost exactly the same on chest x-ray as ARDS. As a matter of fact, some people call it ventilator-induced ARDS. And it can be happening because ventilation is happening at high volume, but it can be happening at low lung volumes as well. Remember that there are all kinds of metabolic processes that are happening in the lungs that we're disrupting with the machine. Now, if somebody is desatting on the ventilator, that's the biggest troubleshooting issue you need to know about. Because if you're already intubated and you're desatting, I don't have a lot of things I can do to fix that. We learned the DOPES mnemonic, which some of you may be familiar with, called displacement, obstruction, pneumothorax equipment, and stacked breaths. But I always like to think about it in terms of what I would actually do when I'm standing in front of a patient. So what I actually do is I detach them and bag the patient every time. Until I can figure out the issue, I'm going to detach the patient from the vent. Next is I always like to get out a gyroscope and check the ET tube. You'd be surprised at how often that ET tube becomes dislodged or the cuff has burst and is now leaking. You know, moving patients back and forth to get more x-rays or radiology scans or even back and forth to surgery can really dislodge or change that tube. That's also true for patients who were brought in and accidentally intubated in the esophagus. Lastly, I'm going to go ahead and have somebody bag the patient while I listen to breath sounds. What I'm really listening for is either right main stemming the patient or something like a pneumothorax. And finally, I have had a couple of patients who we put them on the vent, they started desatting, and then we noticed that there was no chest rise and the vent was on, but for some reason it wasn't working. Or somebody tripped over the cord, or who knows what. They forgot to attach the patient to the vent. I've heard about stories about that. So always check these couple things and start troubleshooting by detaching the patient every time. Next is I wanted to clarify patient vent desynchrony, or what happens when patients fight the vent. Again, I want to clarify that this doesn't mean that patients are being jerks. Okay. It's not a willful patient. It's not that they're fighting medical problems, and they're not just trying to make your job harder. You wouldn't like having a tube shoved in your throat and air forced into your lungs and then sucked out either, which means that fighting the vent is instinctual. It also means that we shouldn't just jump to paralyzing the patient because they're trying to tell us something. So if the patient is coughing, number one thing that you need to do is think that that means that there's secretions that need to be cleared. So you should probably get the RT or somebody to suction out the tube. Next is you can humidify the air that the patient is breathing. And if you can't figure out how to do that, even with normal saline, you could just give them some albuterol to help with the coughing. And then your last ditch effort is to paralyze the patient if you can't get them to stop. Next is hyperventilation. You got to ask why. Patients usually don't overbreathe the vent for no reason. You got to think about the pathophysiology in the chest x-ray. If there is a reason that the patient is hyperventilating, maybe they're extremely acidotic and they're trying to blow off all of the CO2. Or maybe they're hyperventilating and causing all of that CO2 to be blown off. Whatever the case, think about it and consider changing the settings or the mode rather than just instantly going to paralyzing the patient. Next is breath holding. Again, you need to ask why. Maybe the patient needs a little bit more sedation or even pain medications. Or maybe the patient needs a change in their IEO ratio. Next is biting the tube. Don't forget that, again, we're not used to a big plastic tube being shoved into our throat. And it is normal and natural to bite on something that's in our mouths. So, biting on the tube can cause obstruction of the air going in and out of the tube. This is why we have bite blocks. Try one. I've already given you kind of my soapbox rant on not instantly jumping to paralytics, but in case you want to know a whole lot more, there's a bunch of references here, and I really like this guy's stuff. Next, don't forget about post-intubation meds. I know we're talking about the vents, but it's important for you to know that having a tube in your throat and having air pushed in and sucked out can be painful beyond just sedation. The patient doesn't always just rip up and rip out the tube just because of instinct. Sometimes it's because of pain. A lot of patients do really well on just a fentanyl drip, and they don't start bucking the vent and going crazy and thrashing around violently if they just have a little bit of pain medicine. So it's worth your while to play around with a little bit of pain medicine before you start a whole bunch of sedation medicine or paralytics. Finally, let's get into some special cases that are a little bit different than everything else. First is ARDS, or adult respiratory distress syndrome. I'm sure you've heard this as I've gone through all of the information through this lecture, but it's essentially pulmonary edema. It's got to be in both lungs, and it cannot be related to heart failure. Again, if it's caused by the ventilator, it's villi. If it's not caused by the ventilator, because maybe it was there before then, usually the most common cause of this is sepsis. There's a bunch of studies that have been done about ARDS, and we've used this quite a lot for COVID patients. But what you need to know is that there's been developed something called a lung protective protocol, which is essentially just having low tidal volumes and high PEEP. This means that the patient is going to become hypercapnic, of course. So we allow them to be hypercapnic as long as the pH stays 7.2 or higher. We also know that they're going to have a little bit of hypoxia because they have all this fluid in the lungs and they have really low tidal volumes. This means that as long as their sats are in the 90 percentile, we leave them be. This is the ARDS protocol. If you want to get extra fancy, try to keep your plateau pressure less than 30. A lot of the studies that I've mentioned before, some of the stuff should look familiar, but a lot of them have all come from ARDS information. So if you're interested, definitely take a look. Here's some more information about proning. I think I've already beaten this to death. Now let's talk about obstructive issues. Specifically, I'm referring to asthma and COPD. Both of these problems have the same issue for different reasons. Both of them cannot get the air out, or they're having a hard time exhaling. In asthma, it's caused by high resistance. Notice a normal airway here and then a swollen airway here. Because the radius has gotten smaller, this has increased the resistance and they have to work a lot harder to breathe, specifically to get the air out. Now, if you look at the bottom, this is normal alveoli, and this is somebody with COPD. You can see that there's considerably less surface area to exchange air back and forth. And there's also a lot less recoil or compliance. Because they have poor surface area, they're not able to recoil as well, and therefore they're not able to passively get the air out or exhale. All of these and both of these are a problem and can result in ventilation. What you need to know about it is both of these need lower tidal volumes because their airway is either being taken up with the swelling or their airway and their lungs can't hold as much air. Both of these patients are also going to be retaining CO2 because they can't get the air out. Therefore, their body is going to tell them with every fiber of their being that they need to hyperventilate. This is the exception to the rule where rather than letting them hyperventilate, we typically want to paralyze this patient and we want to change the IE ratio to allow them more time to exhale. This will fix a lot of their issues, including their acidosis, but it's kind of counterintuitive than what their body wants them to do. One of the most concerning things and one of the most tested things about ventilators and obstructive problems is breath stacking. This means that because that COPD or asthma patient isn't able to get air out, air goes into the lungs and then doesn't have enough time to come out. And so it slowly builds up in the lungs. And with it builds up the CO2 to where they actually start stacking breath upon breath upon breath without being able to completely exhale. This really increases the amount of volume in the lungs and the amount of CO2 until the lungs are full of nothing but CO2. You can see how this would be an issue. The way to fix this is to disconnect the patient from the ventilator, as we talked about before, and actually physically push on this patient's chest to get all of the air out completely. And then you need to change the respiratory rate to be lower to allow for a longer IE ratio. Typically, they say they want 1:8 or up. And then finally, we get to some pediatric considerations. There's a couple of anatomical considerations you need to know. Specifically, if we're delivering an infant in the emergency department, especially if there's a preemie, that very first breath, the amount of pressure that it takes to pop open those alveoli the very first time is really large. So, because of that, surfactant really helps with the pressure needed to pop open those airways. And we don't want to pop this little baby's lungs. So, it's important that you know that surfactant is something that we put down an ET tube if we have to intubate a newborn infant or a premature infant. Surfactant is available in the emergency room, and you should know to ask for it and put it in the patient's lungs intentionally to help them breathe. You also need to know that because of the anatomical differences between a pediatric patient and an adult patient, Kids under 12 years old cannot get a crike. This means for any reason, physically, anatomically, can't get one. You can do something called a needle crike, but that you can't ventilate very well because think about how little a needle is versus an ET tube. So don't let it get to that point. Also, pediatric patients, especially young ones like the babies and the newborns, they can't tolerate hyperoxia, which means too much oxygen. So don't push for 100% SATs all the time. Again, we're finding more and more that 96% to 94% is more than enough. Note that the appropriate settings for any vent can be found on the Broslow tape. Be sure to ask for that. All you have to do is measure the baby's height. Notice that the respiratory rate is going to change drastically by their age, and PEEP tends to be higher than it is in adults, but it doesn't mean that you need to blow out the baby's lungs. It is also important for you to know that you should not connect a baby to an adult ventilator. You need a special baby ventilator to make sure we're not blowing out the lungs. It's also important for you to know that some vents have a pediatric mode or setting that they can turn to. So it doesn't always have to be a physical different machine. And this is just a reminder of when to intubate and when not to intubate, or when to ventilate and when not to ventilate. Here's our airway spectrum with a reminder to try at least one other thing before we're intubating. And that does it for today's lecture. Please let me know if you have any questions about this. And until next time.